research interests lie in using machine learning methods to study inequality in healthcare. And they're going to be talking about machine learning to increase equity in healthcare and public health.
Thank you. Do you want me to share my slides?
Yes, please.
Perfect. Can you enable screen sharing for me?
Hold a second.
Thanks.
Mushkan?
Yes, you can share your screen. Right?
I have power now. Thank you.
Thank
yes,
you.
Perfect. Good. This is not what we want. We want this. Okay. Great. All right. Can you see me and hear me okay?
Yep, coming through fine.
Perfect. All right, great. Thanks so much for the invitation to be here. I'm really looking forward to this talk today. I want to talk about using machine learning to increase equity in healthcare and public health. I'll motivate this talk by pointing out a couple simple facts. The first is that healthcare and public health remain profoundly inequitable. And this is true in the United States, where I work. It's true worldwide. COVID is maybe exhibit A of this, but there are myriad other examples of this as well. Also pretty well known at this point is the fact that algorithmic approaches have at times exacerbated health inequity, right? And maybe exhibit A here would be a paper which appeared in Science in 2019, dissecting racial bias in an algorithm used to manage the health of populations. Basically, the authors showed that a widely used algorithm designed to predict health risks exhibited racial bias in that Black patients with a given risk score were sicker than white patients with the same risk score. And the reason this happened is because the algorithm was trained to predict how much money the healthcare system would spend on a given patient. And due to historical disparities in access to care, Black patients had less money spent on them and were therefore rated by the algorithm as less risky than they truly were. So algorithmic approaches on the whole are no panacea to health inequity and indeed have exacerbated it at times. But today I want to focus on a more optimistic counterpoint, which is the focus of my work, which is about how algorithms properly applied can also provide powerful tools for understanding and potentially reducing health inequity. And broadly, my work seeks to do that through two general pathways. The first is by trying to use sort of algorithmic and data science approaches to make fairer decisions, whether by detecting and reducing bias in human decision-making or by doing the same in algorithmic decision-making. And the second pathway is by sort of using data science approaches to understand the health of understudied populations. And I've done this in various settings as well. Today, I'm going to be telling you two specific stories along this general research agenda. And the first is about policing, and as I'll point out, this has connections to medical testing. And the second is about using race as a predictive feature in clinical algorithms. And you might say, what do those stories have to do with each other? Is this totally disconnected? In fact, as I'll argue to you, I think there's a deep connection between these two things because they're both about missing data and its connections to health inequity. The first story is a story of human bias and how it relates to missing data. And the second story is about algorithmic bias and its connections to missing data. So let's jump right in. Let's start by talking about human bias. So today I'm going to be talking about policing. And, we care about policing for many reasons, one of which is that it is, in fact, a public health issue. In the United States, it is one of the leading causes of death for young men, somewhat shockingly, particularly for young African-American men. And the specific setting we study is police traffic stops. And why do we care about police traffic stops? Well, they're one of the most common ways that Americans interact with the police, with tens of millions of Americans stopped every year. And of course, at times, those stops can really have deadly consequences. So this is, this is not a minor matter here. This is a profound way that we interact with the police. And there's quite a lot of evidence that traffic stops may be racially discriminatory. And to be very clear what I mean about racial discrimination here, this is when someone is treated more negatively specifically because of their race. So for example, someone is stopped by police because they are Black. They would not have been stopped had they been driving identically, but they've been white. And there's substantial prior evidence of racial bias in police stops. And this comes from many academic literatures. You know, it comes from economics, it comes from sociology, it comes from statistics, other literatures as well. It also comes from non-academic literatures, right? It comes from the lived experiences of Black and Hispanic drivers. It comes from journalists who have looked into this. It comes from police body cameras. Like we have a lot of evidence of this at this point. However, it is difficult to quantify this across the entire United States, and that is in fact the goal of this project. So why is this challenging to do? The first challenge you encounter is that there is no national data set which tracks every stop which happens in the United States. Rather, the way policing data is tracked in the United States is that every state and local police department tracks data in its own idiosyncratic format in its own particular database. So we set about creating such a data set, and this basically happened in two stages. In the first stage, our journalist collaborators submitted data requests to more than 150 police departments over the course of 5 years. So this was, you know, about as much work as it sounds like on their part. It was really a massive undertaking that they underwent. And then in the second step, you know, all that data comes pouring in, but of course it's all in a million different formats. And I'm not going to go into any details about this, except to say that, you know, this encompasses tens of thousands of lines of code to put this into any kind of standardized form that you can analyze. The good news, though, is that we've done that work for you, and the data and the code are now totally available online. So if you're looking for something to analyze, you know, we wrote a couple of papers on this, but frankly, you know, one or two papers can only really scratch the surface of what is possible with data like this. And so you should think of what I'm about to show you as sort of a start, but by no means the only thing one could do with this data. So in our main analysis I'll be telling you about today, we look at about 95 million stops. The reason that number isn't the whole data set is because we have to apply various filters. So for example, we have to filter for the departments that even have the requisite data to analyze racial discrimination at all. Some departments don't track race, for example, which makes it much harder to do so. Okay, so in our analysis, we look at three questions. We look at whether the police discriminate in whom they stop in the first place. We look at whether they discriminate in whom they search after stopping them. And then finally, we look at the effect of policy changes, specifically the legalization of marijuana, upon these racial disparities. And today I'm only going to tell you about that second question, although you can find the answers to the other two in the paper as well. And the reason I do this is because the methods, as I'll argue, are actually much more widely applicable to studying bias in many other human decisions. So, are police searches discriminatory? A little bit of necessary context about police searches. So when the police stop the driver, they're allowed to conduct a search in order to find contraband. So contraband here means things you're not supposed to be carrying under the law, so illegal drugs, weapons, etc. The purpose of a search is to find contraband. It cannot be to like harass the driver or because the officer is bored or they're trying to make a quota or something like this. And so the definition of discrimination that we test for, the specific type of discrimination that we test for, is whether minority drivers are being searched when they are less likely to have contraband at a lower threshold of evidence. So concretely, if Black drivers are being searched when they're only 10% likely to have contraband, but white drivers are being searched like only when they're 50% likely to have contraband, then that difference in thresholds by race, that's discrimination under our definition. Now, clearly, this is bad if it's happening, but importantly, this is not a comprehensive definition of all types of problematic police behavior. It says nothing, for example, about disparities in police use of force. So while this is a particular and important type of discrimination the police might be engaged in, there are many other things that you might test for in this data set as well, which is why we make the data available. Now, I told you this was a talk about missing data. This is, in fact, a missing data problem. Why? Because we only observe the outcomes of the searches, namely whether those searches find contraband, for the people the police historically searched. For the people they don't search, we don't know whether those people were carrying contraband because no one ever looked for it, right? And so the outcome data is censored by human, specifically police, decision-making. And this is a very tricky type of data censoring because humans, of course, are potentially biased. That's exactly what we're seeking to test for. But humans also potentially have access to many unobservables. And an observable is something that is like relevant to the decision, relevant to the outcome of the decision, but not observed to the analyst, only observed to the decision maker. So for example, if the driver is acting nervous, that might be relevant to the officer's decision to search them, but it's not written down in the data. All of these things mean that the unsearched population may differ in very important ways from the searched population. What this means is that we cannot simply train a model on the population who was searched and assume that it was generalized to the rest of the population as well. More broadly, this type of problem where human decision-making censors the outcomes that we observe is known as the selective labels problem. That's one name it goes by. Economists will call it something else. Many literatures talk about this problem. And problems of this form, as I'll discuss in a bit, appear in many other settings as well, including hiring, lending, recommender systems, medicine, myriad high-stakes examples where this basic structure appears. So to return to searches, how might we test for discrimination in this decision? Well, the first simple test which has been proposed is look at search rates, namely, how likely are drivers of different races to be searched after a stop? And when you do this, the results are plotted at right, and immediate and striking disparities appear with Black and Hispanic drivers far more likely to be searched after a stop than are white drivers. But higher search rates on their own do not prove that the police are applying different thresholds to different race groups. It is possible that some groups are more likely to be carrying contraband. The purpose of a search is to find contraband. And so some groups are more likely to carry it. The police may be more likely to search them, even absent applying different thresholds. So a second test which has been proposed is, okay, don't look at the rate of searches, look at the outcomes of those searches. Specifically, look at how likely those searches are to find contraband. We call that the hit rate. So what fraction of searches find contraband by race? And the intuition for this is like, look, let's say that, searches of white drivers are finding contraband 90% of the time, but searches of Black drivers are finding contraband only 10% of the time. It suggests that the police are searching white drivers only if they're very likely to be carrying something, but they're searching Black drivers on the basis of less evidence, suggestive of discrimination. So if the hit rates vary by race, that is discrimination under the outcome test, or it's suggestive of discrimination under the outcome test. And when you look at the data, that is in fact exactly what you see. You see that the hit rates for Black and Hispanic drivers are lower than those for white drivers, suggesting discrimination under the outcome test. But it turns out that there's a problem in the outcome test as well, and this is a statistical issue known as infra-marginality, and I'll illustrate this to you with a simple hypothetical example. All the data in this slide is completely made up, it's just to illustrate a point. Imagine that there are only two race groups. There are Black drivers and there are white drivers. And imagine among each group, there are two easily distinguishable groups, those who are very likely to carry contraband and those who are quite unlikely. Among the likely group, 50% of Black drivers and 75% of white drivers carry contraband. And among the unlikely group, 5% carry contraband irrespective of race. And importantly, imagine in this hypothetical example that the police are not being discriminatory. They apply a uniform 10% threshold to both race groups, searching everyone who is more than 10% likely to carry contraband. So what's going to happen in this hypothetical example? Well, the police are going to search all the likely drivers, right? And they'll end up with a hit rate of 50% for Black drivers and 75% for white drivers. So under the outcome test, it will look like the police are being discriminatory, even though by hypothesis in this hypothetical example, there is no difference in the thresholds being applied. And importantly, the outcome test can also yield a misleading result in the other direction, where it fails to find disparities in thresholds, it fails to find discrimination, though in fact it is occurring. So why is this happening? Why are we getting this misleading result? Well, it's happening because the statistic that we're measuring, the probability someone is carrying contraband, conditional on being above the search threshold, is not actually what we're trying to measure, which is the search threshold itself. Those are simply different mathematical quantities. And so, the threshold itself is not easy to measure. It's not a simple fraction, for example, the way the hit rate is, right? It's a complex latent quantity in the data. And so the solution that has been proposed is to use a Bayesian latent variable model to attempt to infer this threshold. This is known as a threshold test, and it was proposed in 2017. It proposes a stylized model of a police stop. And the goal of this model is to estimate search thresholds that are consistent with the observed data, namely the search rates and hit rates. And discrimination under this model, as before, is if lower search thresholds are being applied in searches of minority drivers. So how does the threshold test model a police stop? Well, it assumes that when the officer stops a driver, they estimate the probability P that that person carries contraband. P is drawn from a risk distribution. That's just a distribution on the unit interval, so ranging from 0 to 1. And I've shown an example graphically at right. And you should think of P as sort of summarizing like all the sort of relevant features about the driver into a single measure of the probability that they're carrying contraband. So for example, in the case of a bus driver, if they get pulled over, P would probably be quite low, right? Because they're like driving kids around. They're hopefully not, also driving guns around or something like this. So P would be low. On the other hand, if the officer pulls over someone who is acting woozy and drinking out of a bottle, then P would be probably higher. The officer observes this P, and if P exceeds the threshold, the officer searches the person, and if they search them, they find contraband with probability P. So, for example, in the case of the bus driver, he'd be below the threshold, the officer wouldn't search him, wouldn't find contraband. In the case of the woozy acting driver, he'd be above the threshold, the officer would search him and would find contraband with 75% probability P. The model allows the thresholds and the risk distributions to vary by race group and by location. And discrimination, as before, is if lower thresholds are being applied in searches of minority drivers. A couple details about model fitting, which I'm not going to go into huge detail now. Basically, because this is a Bayesian formulation, you need to specify the mapping from the unobserved objects, namely the thresholds and the risk distributions, to the observed quantities, namely the search and hit rates for each race and location. And it turns out that there are relatively simple mathematical forms which do that mapping for you. To complete the Bayesian specification, you have to put priors on the model parameters, specifically the thresholds and the risk distributions, and then you can, do posterior inference using standard, MCMC methods. In this case, Hamiltonian Monte Carlo. Okay, that sounds simple. Actually, it doesn't work at all. It turns out because the original authors implemented this using beta distributions, and the requisite quantities you have to compute using beta distributions are prohibitively slow on data of our size. This has a couple implications. The first is, for us specifically, it means that we can't fit a model on the entire national data set. It's impossible. It just doesn't scale. And further, more importantly, I think, the test can't be used by people who really need it. So journalists, activists, well-intentioned police departments, et cetera, anyone who sort of doesn't have access to a ton of computational resources and statistical expertise. So that really limits the practical applicability of this thing. So to deal with this problem, basically what we do is describe a new family of probability distributions termed discriminant distributions, and we use them to make a version of this test that runs about 100 times faster, which really, first of all, makes it possible to run on our national data set, but also, makes it possible for practitioners to actually use this test. I'm not going to tell you about those distributions in detail, but I will tell you about the results, which is that with the fast threshold test, you're able to fit a national model. And I'm showing you the results of doing so here. You can see that the inferred thresholds for Black and Hispanic drivers are lower than those for white drivers, again suggesting discrimination against Black and Hispanic drivers who face lower thresholds to get searched. So to summarize what I've told you today, I've shown you three things from our search analysis. I've shown you that search rates are higher for Black and Hispanic drivers, hit rates are lower, and thresholds are lower. This is a characteristic sort of smoke and gun pattern for discriminatory searches. You'll see it in other contexts as well. For example, if you look at stop and frisk data in New York City, which was a very obviously discriminatory policy, which was in fact found to be unconstitutional by a federal judge in 2013 and subsequently curtailed. All three tests here are suggesting discrimination against Black and Hispanic drivers, but the threshold test is doing so in a way which is robust to the statistical flaws of simpler tests. Now, to speak briefly about the public policy impact of this work, I mentioned that one benefit of making the test more applicable is that it can be used by a wider number of practitioners. And indeed, in 2019, the Los Angeles Times was able to take our fast threshold test with some help from our team and use it to show that the LAPD, the LA Police Department, was searching Black and Hispanic drivers on the basis of less evidence than they're searching white drivers. And in response to that, within about a week, the LAPD announced that they would dramatically cut back on random vehicle stops in an effort to ameliorate this racial bias. So this was sort of a setting where the statistics actually did translate into policy change. Now, I do want to talk about the broader context of problems like this, where you only observe sort of gold standard outcomes, like whether the search finds contraband, for a selected subset of the population. Specifically, you can basically take the same statistical playbook and apply it in other data sets where you have a binary decision, and then you observe outcomes for the subset of people who get a certain decision. So for example, in lending, the decision might be, does the bank grant a person a loan? And the outcome would be, do they repay it if they are granted the loan? And discrimination in this context might look like minority applicants are less likely to receive loans, but more likely to repay them if they receive them, suggesting that they are receiving loans only at higher sort of thresholds, right? Similarly, in medical testing, the decision might be, should we test a patient for a disease? And the outcome would be, if we do test them, do they test positive? And discrimination in this setting might look like minority patients are less likely to get tested for a disease, but conditional on being tested, more likely to test positive, suggesting that they're getting tested only if they're likelier to be sick. So I hope I've convinced you that this is an important problem. It's also unsolved. There are long relevant literatures in multiple fields going back, about 50 years at least. And in general, my argument would be that this problem is unsolvable without further assumptions. It's not really the kind of thing you can solve in full generality. And the reason is that, without making further assumptions, the untested population, the unsearched population, could have any distribution. They could all have contraband, none of them have contraband. And without sort of making further assumptions to constrain that range of possibilities, it's quite hard to make headway here. I would further argue that domain-specific solutions here are probably useful because which assumptions are actually reasonable varies by domain. It's linked with the data generating process, and that is necessarily domain-specific. So for example, in policing, in the setting I introduced to you here, the data are often extremely limited. Departments often don't keep very good records or make them available to the public, meaning that you need to make sort of strict assumptions in order to allow the threshold test to work from relatively little data. So for example, you have to assume that the risk distributions have certain parametric forms. In contrast, in healthcare, the data can be much richer, right? You might have years of data with thousands of observations, images, medical notes, et cetera, for a given patient. And in that richer data setting, there might be better solutions than the threshold test, which is sort of specifically optimized for a sparse data setting. There are also other sources of side constraints. For example, you might know the overall prevalence of a disease, and that means that you can constrain the fraction of the untested population who have it, right? How do we know, for example, that if 99% of people aren't tested for a given cancer in a given year, how do we know that most of them are going to test negative? Because very few people ultimately get the cancer, right? So that allows us to constrain the untested population. And just as a sort of sneak preview of where we might go with this, this is a paper I wrote a couple of years ago, basically taking the same statistical playbook and applying it to look for evidence of bias in COVID testing, and indeed did reveal evidence of that basically, Black and Hispanic patients were less likely to get to COVID tests, more likely to test positive if they got them, overall suggesting that they were receiving tests only at sort of higher likelihoods of actually having COVID. All right. So that's the first story. That's about missing data and its implications for sort of human bias. Let's move on to the second story, which is about missing data and its implications for algorithmic bias. This is joint work with Anna Zink, who is a postdoc at UChicago, and Ziad Obermeyer, who's a professor at UC Berkeley. And it is a working paper in contrast to the previous stuff, which was based on published papers. So your feedback is very welcome. Okay. So there is currently a high-profile debate going on in the medical community about whether we should use race as a predictive feature in medical algorithms. And when I say high-profile, I don't even just mean that it's appearing in medical journals, although it is. More importantly, it has direct and immediate consequences for patient care, because basically hospitals and other clinical providers are literally changing the way they compute important medical quantities right now, and that has a lot of downstream implications for how patients are treated. So hospitals are changing this, US senators are inquiring into it, lots of stuff going on here. So, for those of you who are not doctors, I'm not a doctor either, well, not a real doctor, or a useful doctor. Okay, whatever, let's not be too self-deprecating here. Anyway, let me give you a specific example of when race is used as a predictor in clinical algorithms. Probably the most widely known and discussed and debated setting is what's in computing something called GFR. Which is an important measure of kidney function. And so we refer to the estimate of eGFR. So, eGFR is an important thing to try to estimate because it has all sorts of downstream consequences. For example, are you diagnosed with kidney disease? What kinds of drug doses can you get? Are where on the list are you for kidney transplants and kidney donation and all this kind of stuff. So it's quite important, sort of life or death consequences of the way you compute this particular measure of kidney function. And on the left side of the slide, I've shown you a screenshot from the online calculator MD-Calc. So MD-Calc just compiles a bunch of sort of medical algorithms for easy access for clinicians. And what you can see is that basically, historically, whether or not the patient is Black will change the number computed for eGFR. So if you click, no versus yes, you'll literally get a different output. And now many hospitals are sort of revisiting whether they want to do that. And people have written papers specifically sort of documenting the likely consequences that will have for patients, which are, significant. So this is happening in nephrology, with respect to kidney function, but it's also happening in many other settings as well, cardiology, obstetrics, urology, et cetera. And if you want to see a nice review on this issue, I'd point you to the paper at the bottom of this slide, which has sort of a table chronicling many of these settings. And to be very clear, there are very good reasons for this scrutiny, and I want to just review a couple of them. The first is that some of these race corrections have been based on extremely sketchy empirical data. So think, small data sets, non-diverse data sets, like studies done in 1952 that are now somehow applying to, very different patient populations decades later, right? So just from a sort of pure statistical standpoint, you might be nervous about the way this is happening. Second, there are very justified concerns about exacerbating health disparities. So for example, if your cancer risk prediction algorithm includes, a race term, right? And the consequence of that race term is that, for example, Black patients are rated as lower risk of cancer than otherwise identical white patients, then in turn, those Black patients might be sort of lower priority for screening, and that might exacerbate historic disparities in access to screening. So you might have very justified concerns about exacerbating health disparities. And then finally, there's a long bad history of racist beliefs about biological racial differences in medicine. So for example, there was a recent article just documenting the widespread false belief amongst radiologists that Black Americans needed higher radiation doses from X-ray machines. And that's about as bad as it sounds, right? That's clearly very dangerous for patient care. Similarly, there are long and well-documented false racist beliefs about differences in sort of pain perception by race. So, on the basis of this, you might be very nervous about sort of algorithms that attempt to include race corrections. At the same time, consequences of removing race from these prediction algorithms remain unclear, right? And it's pretty clear that removing predictors in clinical algorithms that have life or death consequences is something that ought to be done carefully. Here's an op-ed which appears in the New England Journal of Medicine a couple of years ago, with basically all the authors saying, please, let's be careful here. We urge our colleagues in medicine and science to refrain from haphazardly removing race from clinical algorithms and treatment guidelines. So in light of this debate, the argument that we make is that removing race as a predictor can have unintended consequences, and indeed, paradoxically, decrease equity. And the specific case we present in which this occurs is intimately linked to the missing data, which has been the theme of this talk. Specifically, when racial bias creates differential rates of measurement error or missing data between different groups. So what do I mean by racial bias creates measurement error? It makes it more likely, basically, that some race groups will have critical risk predictors mismeasured. And there are a billion examples of this in medicine. It is incredibly ubiquitous, right? We just talked about disparities in testing, right? Some groups might be more or less likely to get necessary tests when they're sick. And if you don't get the test, you don't have the data on the test result, right? There are disparities in underdiagnosis. There are disparities in whether medical records are there at all. The overall theme being, we wrote a review paper on this a couple of years ago, but the overall theme being that the quality of data and sort of the rates of missingness and the rates of error just vary substantially across race groups. And the specific and important risk predictor we focus on in our analysis is family history. Why do we focus on family history? Two reasons. The first is that it is a very important predictor of disease. So you go in for, I don't know, a mammogram or something, the doctor will certainly ask, do you have a family history of breast cancer, right? Just because it is a known risk predictor for these things, right? But the other reason family history is something we focus on is that there is substantial previous work suggesting that it is more likely to be mismeasured in some race groups. Specifically, previous work has shown that clinicians are less likely to ask non-white patients about their family history, and in turn, these patients may have higher rates of unknown family history. So for multiple reasons, there are higher rates of missingness in this critical risk predictor. So the data set in which we study the role of family history is called the Southern Community Cohort Study, which is a cohort study established in 2001 to try to study health disparities broadly and cancer disparities specifically. It's a racially diverse data set collected throughout the southeastern United States, and we study how colorectal cancer risk, a very common type of cancer, varies by race and family history. So what I'm plotting for you here is basically family history, risk of colorectal cancer as a function of age for white patients. And it's broken down by whether or not the patient reports family history. The reason we plot it as a function of age is that risk of basically all types of cancers increases significantly with age. So that's important to stratify by. And, the results of this are pretty obvious, right? That basically for white patients, family history is strongly predictive. The light blue line is well above the black line. But for Black patients, the story is different. Now the two lines are basically on top of each other. And if you fit a regression model, you see that the odds ratio is no longer statistically significant, indicating that in Black patients, family history does not have a significant predictive value. In contrast, in white patients, it has a highly statistically significant predictive value. And this is very consistent with what we would expect if there was differential mismeasurement of family history across race groups. Basically, if Black patients who truly did have family history were being falsely recorded as lacking it. So what that does basically is it means that recorded family history is no longer as good a measure of true family history, which is, of course, what you would ideally like to observe, right? And in general, this phenomenon is known as something called regression dilution or regression attenuation. Basically, if you do the regression, cancer risk regressed on family history, but family history is mismeasured, that's going to tend to bias the coefficient on family history towards zero, right? And the way to think about this intuitively is imagine family history were totally randomly measured, right? So rather than observing true family history, you just observe a random variable that has no relationship to the real thing. Then in that case, the coefficient is just going to be zero. And in sort of intermediate levels of mismeasurement, you just get sort of this shrinkage back towards zero. Okay, so all of this means that due to differential rates of mismeasurement of family history across race groups, the coefficient on family history is very different in white patients and in Black patients. And if you want to allow a model to accurately capture the effects of that differential mismeasurement, the way to do so is precisely with a race term, specifically an interaction between race and family history, which is highly statistically significant in our analysis. We also find that fitting a risk predictor which uses race, namely both the sort of base race term and that race interaction term, increases the fraction of Black patients among the predicted high-risk group. So if you sort of look at the patients who get the highest risk scores from the algorithm, and then you say what fraction of those predicted high-risk folks are Black, then you basically see that if you use the race-corrected algorithm, it increases the fraction of Black patients among the high-risk group, as opposed to the race-blind algorithm. It also improves upon the race-blind algorithm in a likelihood ratio test, indicating basically a statistically significant better fit to the data. So in this case, this could potentially increase racial equity by sort of increasing the fraction of Black patients who are eligible for screening, which is, of course, useful if it prevents cancer in those populations. Okay. So to summarize the results of our analysis, it's clearly true that the use of race, the scrutiny of the use of race in clinical algorithms is extremely justified. There are a number of reasons that it's very important that we're having this discussion now. At the same time, removing race can have unintended consequences, sometimes even decreasing equity. And we illustrate this point through a case study of mismeasurement of family history. I want to briefly highlight a related result. This is not from our work, this is from other work, but it's very relevant, so I'm going to mention it, which is that even if you remove race, the algorithm can potentially reconstruct race anyway through proxies in medical settings. So this point has been known generally in algorithmic fairness for a long time, right? The idea that fairness through blindness is in general a pretty weak way to guarantee fairness because algorithms can often reconstruct sensitive features through features which are correlated with them. But it's recently been shown that this is true in the medical setting specifically. Specifically, the authors showed that if you give an algorithm an X-ray of a patient and you ask it, can you predict the patient's race from the X-ray, the algorithms can often do so with sort of eerie and disturbing accuracy. And furthermore, it can continue to do that even if you distort the image in various ways. And furthermore, the authors aren't really sure why this is happening. So this is very worrisome for a number of reasons. things, I would say. But the overall point is simply removing race from medical algorithms is no guarantee that the algorithms won't effectively end up using race anyway, because they can reconstruct it through proxies. So to conclude, I don't think that the solution to racial bias in clinical algorithms will come merely from excluding race, both because, as we show, this can potentially decrease equity, but also because algorithms can often reconstruct race anyway. Instead, we think it's important to think carefully about the goal of clinical algorithms, here predicting cancer risk, and how various algorithmic design choices can advantage or disadvantage different groups with respect to this goal. So to conclude, today I told you two stories about missing data and its connections to health inequity. The first was about policing and also about medical testing, and it was a story of human bias. And the second was about the use of race in clinical algorithms and thereby connections to algorithmic bias. Thanks very much for your attention. I'm happy to take any questions.
Great, very, very interesting stuff. Thanks very much. So again, if anyone wants to put questions in the chat, or feel free to unmute yourself. We'll keep an eye on both of those. So one of my specialisms is measurement error. So I was very excited when that word came up. So one question I just had, this is maybe getting into the weeds a little bit on the asking for family history being dependent on race or ethnicity. One just thought I had during that was, so clearly you've got evidence that you have whether or not family history is asked for is sort of differential based on that group membership. Were you able to, or did you look at whether it was differential in other senses, like, you know, within non-white groups? Was family history being asked for related to other factors, like were patients who were higher risk more likely to be asked for their family history, that kind of thing?
Yeah, that's a great question. So I should clarify that in this is a self-reported survey. So the results of family history here are reported by the patients themselves. And so our hypothesis basically is that patients are saying that they have no family history when in fact they may have family history. Like somehow, you know, they're not getting good medical information or something like this. I think it would be very interesting to study in medical records, like sort of study whether you can predict the missingness variable itself on the basis of the patient's high risk status. That may have been done. I'm not sure if that's been done in prior work, but it would definitely be interesting, and you could definitely do it.
I have a question.
Oh, yeah, please go ahead.
Yeah, it was kind of along the lines of what you were asking, Michael. Like what other information might help us identify better the key question. And, you know, not just in the medical. So I also didn't understand that this was self-reported, and was thinking, you know, could it have to do with the doctor and having the doctor being in a certain location or a similar race, right? But with respect to the traffic stops as well, like, so I'm curious, we can make assumptions on the distribution and get some information, but we have alternative techniques to try and understand or get a better, you know, estimate of potential biases given sample selection. But what, like, say one technique could be that additional information, like, for example, what was visible when the traffic stop occurred? Like, did the traffic stop occur behind the car or after having passed the car and observed who the driver was, kind of thing, which is kind of and so I guess, because I'm all over the map here, my question is, have you looked at or any sense of whether or not those types of techniques result in similar level of clarity as making the distributional assumptions in order to try and get an answer to these questions? Like, how do these different techniques measure up against each other?
Yeah, I think that's a great question. So none of these things are going to free you of the need to make assumptions about the untested population. Like that basic issue is that's gonna be a through line here. Absolutely. Right? Yeah. But I think it's definitely the case that sort of in the rich data setting, you can do other things besides the threshold test. And what would be an example of this in a policing setting? So for example, our co-author Shard Goel wrote a paper entitled, I think it's called like Omitted and Included Variable Bias in Tests for Disparate Impact or something like that. But basically what they do is they fit a rich model of sort of predicted likelihood of carrying contraband. And so, so that's sort of, they're using a gradient boosted decision tree or something fancier like that, using more covariates rather than sort of fitting on relatively few covariates and making strict parametric assumptions. So then what they have is a predicted risk for each driver. And what they do is they try to say, basically what they say is, actually, this is in the pedestrian stop setting, but they say, are Black pedestrians search more than white pedestrians when controlling for risk? So they basically do a risk adjusted regression, but that risk is the product of much richer features. Now, still, that doesn't get you away from the issue that there might be unobservables which are relevant to risk and to the decision and sort of standard causal inference concerns. But nonetheless, it's a way of sort of leveraging the fact that in the specific data that they study there, they have much richer covariates because, it's just better collected. And I think in general, the risk adjusted regression approach is like pretty intuitive and is a reasonable statistical procedure.
So I'm just keeping it to, please feel to speak up if you have your own question. I see something has appeared in the chat.
Oh no, sorry, Michael, that was just me as an economist.
I like economists too. I do like economists. Yeah, no, I think so. No, I enjoy working with economists.
Kay's question did get me thinking, because I did some work a few years ago with a grad student looking at it's sort of race and ethnicity within clinical decision making, and it reminded me of a question we encountered in that literature around the idea of when you are analyzing those kinds of data, it's not necessarily just covariates measured on the patient you want to know. You also potentially want to know covariates measured on the prescribing clinician.
Yeah.
And I just wanted, are you aware of context where it's been possible to get data like that, or is that almost a bit of a pipe dream to hope that we could gather those data, let alone sort of incorporate them into analyses such as these?
No, it's not a pipe dream. I'm speaking a little bit out of my area here because I had, so you should take what I tell you with a bit of a grain of salt. But I will say people have used the race of the decision maker in both the policing and in the medical contexts to sort of see whether there's evidence that sort of you get better treatment if the decision maker is of the same race as the person they're making a decision about. And in the medical context, I think there is substantial evidence, in fact, that, for example, Black physicians can provide better care for Black patients. There's evidence of that from the econ literature, and I could probably track down the paper from you. I think they did actually a randomized controlled trial of actually doing this and observed significant differences. There's also evidence from observational data. I think one thing which can be a bit tricky here, and here's the part where I'm less sure, is that it can be a little difficult to know because patients are treated by multiple people and hospitals are chaotic, and who exactly was making what decision, I think is sort of an ongoing challenge here. There's probably also challenges around providers not being randomly assigned to patients, and how do you deal with that? But people have studied this, and it is an active area of study, and I think there is some evidence of effects.
Very interesting, thank you.